Welcome. Today we're exploring chest pain in the emergency department as an undifferentiated symptom. We'll walk through 4 realistic cases: STEMI, aortic dissection, pulmonary embolism, and pericarditis evolving into tamponade to help you build essential clinical reflexes for these can't-miss diagnoses. Our learning objectives are to apply a structured framework at the bedside, recognize key ECG and exam findings for 6 life-threatening causes, prioritize rapid action, use validated risk stratification tools rather than just Gestalt, and translate these scenarios into safe, guideline-concordant management. Chest pain accounts for 6% of ED visits. While most causes are benign, the life-threatening ones require immediate action. Atypical presentations are often missed. The goal here is to develop a reflex, screen every patient against the can't-miss list before concluding the cause is benign. Keep these 6 can't-miss diagnoses in mind: acute coronary syndrome, aortic dissection, pulmonary embolism, tension pneumothorax, cardiac tamponade, and esophageal rupture. We will focus our cases on the 4 most common of these serious presentations. In the first 10 minutes, get an ECG for any chest pain triage. Monitor the patient and gain IV access. Focus your history to screen for the can't-miss list. Use validated risk tools like the heart score, and let pretest probability guide your workup, not a reflexive pan scan. For case 1, a 58-year-old smoker arrives with 45 minutes of crushing substernal chest pain. He has associated nausea and diaphoresis, a history of poorly controlled diabetes and hypertension, and the pain began at rest. Let's look at how we manage this. The ECG at 6 minutes shows an inferior STEMI. Crucially, the right-sided leads reveal ST elevation, suggesting right ventricular involvement. His exam shows JVD but clear lungs. Do not wait for troponin results to begin your reperfusion strategy. When evaluating the differential for an inferior STEMI, check for pulse and BP asymmetry to rule out dissection. Watch for the trap. This patient has RV infarction. His right ventricle is preload dependent, making nitrates and morphine potentially dangerous. Withhold them until RV involvement is addressed. Immediate priorities include aspirin, a P2Y12 inhibitor, and activating the PCI pathway for a goal door-to-balloon time under 90 minutes. If hypotensive with clear lungs and RV involvement, prioritize IV fluid boluses instead of vasodilators. Always confirm medication doses against your institution's specific protocols. Remember, in any inferior STEMI, obtain right-sided leads like V4R to screen for RV infarction. Missing this and reflexively administering nitrates is a major, yet preventable, harm. Stay vigilant during your initial assessment. Case 2. A 62-year-old man with poorly controlled hypertension presents with sudden, tearing chest pain radiating to his back. The pain hit maximum intensity within seconds. Note his vitals. There is a significant blood pressure difference between his arms. Examination reveals a blood pressure differential and a new diastolic murmur, suggestive of aortic regurgitation. While the ECG and X-ray offer clues, they do not exclude dissection. ACT angiogram of the aorta is the necessary test to confirm the diagnosis. Classification is critical. Type A dissection involves the ascending aorta and is a surgical emergency. Type B is generally managed medically unless complicated. Use your pretest probability to decide on imaging. For high-risk patients, go straight to CT angiography. For hemodynamic control and dissection, use a beta blocker first to manage rate and pressure. Only add a vasodilator afterward to avoid reflex tachycardia, which worsens aortic wall stress. Ensure dissection is excluded before considering any anticoagulation or thrombolysis. Final pearl: dissection pain is classically maximal at onset, whereas ischemic pain typically builds. While physical signs like pulse deficits are specific, they are not sensitive. Always consider the patient's full history when determining your diagnostic plan. Case 3. A 45-year-old woman, 3 weeks out from orthopedic surgery, presents with sudden pleuritic right-sided chest pain and shortness of breath. She has no cardiopulmonary history, but she mentions mild calf swelling. Her vitals show tachycardia, tachypnea, and hypoxia, but a normal blood pressure. Do not let that normal pressure reassure you. For risk stratification, we use a validated tool like the Wells score. This patient is moderate to high risk, so we proceed directly to CT pulmonary angiography, bypassing D-dimer. If she were low risk, we would use an age-adjusted D-dimer. If contrast was contraindicated, a VQ scan would be a reasonable alternative. Severity stratification drives your therapy. Low-risk patients are normotensive with no RV strain. Submassive patients show RV strain on imaging or biomarkers. Massive PE involves sustained hypotension or shock, requiring immediate systemic thrombolysis or catheter-directed therapy. Our patient is on the boundary, making RV strain evaluation our next critical step. The pearl here: about 1/3 of confirmed PE patients have a normal heart rate at presentation, and early hypoxia can be absent. Anchor on your pretest probability and a validated score, rather than potentially misleading vital signs when you're deciding whether to image. Our final case involves a 35-year-old man with a recent viral prodrome, now presenting with sharp, positional chest pain that has evolved over an hour into shortness of breath and lightheadedness. He is tachycardic and hypotensive with distended neck veins. We need to act quickly. We are watching Beck's triad emerge, but remember it's insensitive, so don't wait for all components. His ECG shows diffuse concave ST elevation with PR depression, a classic pericarditis pattern. Bedside echo is the fastest way to confirm tamponade, specifically looking for pericardial effusion and right ventricular diastolic collapse. While uncomplicated pericarditis is managed with NSAIDs and colchicine, tamponade requires emergent echo-guided pericardiocentesis. We avoid positive pressure ventilation and anticoagulation, as both can cause further instability. IV fluids may provide a temporary bridge while you prepare for immediate drainage. A final pearl: diffuse, concave ST elevation favors pericarditis, while localized, convex elevation with reciprocal changes favors STEMI. When the ECG is ambiguous or the patient is unstable, a bedside echo will settle the diagnosis much faster than waiting for serial ECGs. Let's summarize. We have covered 4 distinct diagnoses with unique pain qualities, findings, and diagnostic priorities. There is no single pathway for chest pain. Your ability to distinguish between these critical conditions based on their specific clinical features is what drives successful, patient-centered care. Use this framework. If a patient is unstable, get a bedside echo immediately. If stable, let the ECG and history guide you toward the correct pathway. Any positive finding for a can't-miss diagnosis should short-circuit the algorithm, allowing you to prioritize life-saving interventions immediately. Remember these 6 points. Get the ECG in 10 minutes. Screen for all 6 life threats. Check for RV infarction in inferior STEMI. Treat tearing pain as dissection until proven otherwise. Use validated risk scores, and use bedside echo for rapid confirmation in unstable patients. These recommendations are synthesized from major society guidelines, including those from the AHA, ESC, and leading emergency medicine texts. Always ensure your management aligns with your local institutional protocols and current standards of practice. Thank you for joining this review of high-stakes chest pain cases. Stay structured in your approach and maintain your clinical vigilance. We can now move on to questions or further discussion.